Good evening, ladies and gentlemen. Thank you very much for joining us for our ongoing session of Cancer and I. And this is our next installment. And this evening, we're very privileged to be able to have with us a esteemed group of very experienced specialists, consultants who are with Prince Court Medical Center, who is our partner for this segment of Cancer and I. This evening, I'm very privileged to be able to first introduce our first speaker for the evening, Dr. Muhammad Azrif bin Ahmad Anwar. Dr. Muhammad Azrif is a consultant clinical oncologist with Prince Court Medical Center. And Dr. Azrif also wears another hat among a lot of other hats that Dr. Azrif wears. He is the president of the Malaysian Oncological Society. Good evening, doctor. Thank you so much for joining us this evening. And really, we're very honored that we have you this evening to speak for us.
Hello, good evening. Thank you very much for the kind introduction. Yeah, it's a pleasure to be here.
Oh, lovely, doctor. And I'm going to actually steal the first couple of minutes and ask you whether, since for a lot of people in the scene or in the landscape, they all know about MOS, the Malaysian Oncological Society, but for some of our viewers, the name might be something new. So could I get you to kind of explain a little bit about MOS and the work that MOS does in the cancer scene in Malaysia, doctor?
Well, the Malaysian Oncological Society has been around for about 30 years or so. And our role is mainly in continuing professional education among the oncology community. So this includes doctors, nurses, so everyone, surgeons, oncologists, pathologists, radiologists, everyone involved in the care of patients with cancer. We also represent the oncological community in regional and also international meetings. So in the formation of, for example, Pan-Asia, clinical practice guidelines, promoting clinical research. So we kind of like around in the background. We're not like the National Cancer Society up on stage, trying to raise awareness among the public in cancer. We leave that up to you. Our role is more in ensuring our doctors practice according to evidence-based medicine and to kind of like improve the care that our patients receive in clinic. So we believe that everybody has a role to play, and we've decided that this is a role that we should be focusing on.
Right, lovely, doctor, and I think that's one of the most important roles that anyone in healthcare practice actually has, to continue educating and making sure that our healthcare professionals across the board continue to deliver the best quality care, and of course the best evidence-guided care for all our patients. So really, thank you very much, doctor. And I know that this year we have seen a bit more of MOS kind of making its way in quite a bit of patient education as well. We see kind of quite a few campaigns that MOS continues to run together with us and other organizations as well. If maybe doctor would kind of like to share a little bit on some of the ongoing campaigns that maybe the public can kind of get a look at, and where can they go if they want to kind of look for campaigns that MOS is kind of running?
Well, we've been collaborating with the NCSM for the World Cancer Day. So that's been running for, I think, the last couple of years now. The first one was in Penang, and then last year was in KL Central. I think you were there as well, Dr. Muradi.
Right.
And then unfortunately this year, because of the COVID pandemic, everything had to go virtual. So we have been exploring other avenues to reach out to the public. And most recently, we just concluded our cervical cancer public awareness campaign, which we conducted over social media, Facebook and Instagram. So we got about 7 to 8 social media influencers, NCSM, Magna, the program Rose, Women's Aid Organization, etc. So they were all on board. And we kind of like posted content regarding cervical cancer treatment, HPV vaccination, screening, etc. to try and reach out to the public in a different way. I regard that more as an experiment, really, to see whether it was what kind of like response we got from the other societies, our partners, and as well as the social media influencers, right? So I'm quite happy that we got support. We are kind of like reviewing the feedback and data that we receive, and our PR officer is kind of preparing the report for that, which I'll be happy to share with you at a later date.
Good.
That will be interesting. We will email it to our partners as well.
Oh, lovely, doctor. And so, ladies and gentlemen, the first ask for this evening, when you go to watch a movie, you should buy a ticket, and it's like $8, or usually Wednesday it's like $6. So today, the ask from us, the entry ticket is really visit MOS Facebook page, click like and follow. So they've got a lot of information pertaining to cancer, which comes up, and it'd be good for you to kind of have, very importantly, a very trustable, verified source of information. Okay, so thank you so much, Doctor. And today, let's get on to the topic for today. And today, actually, we put a little kind of a funny title to look at. It's for gentlemen, and actually. So the idea is, and I think you are going to speak about this a little bit as well, that for a lot of men, taking care of their health is something very secondary. We're always like, it's okay, it's not too bad, and also sometimes we have a bit of a lot of attention on things like breast cancer, and women are a lot more aware, women are a lot more careful. So maybe this evening we're hoping that you can kind of open our eyes a little to the problems of cancer within men, Doctor. So without further ado, please allow me to kind of turn the stage over to you.
Okay, thank you very much.
Thank you, Doctor.
Let me share my screen. Okay, sorry, not quite used to this.
Oh, no worries.
Okay. Okay, so can you see that?
Yes, Doctor, I can.
Okay,
yes.
I move it to presentation mode. Okay, there we are. Okay. So thank you once again, Dr. Murali, for inviting me to give this talk, and thank you very much to your audience for attending this Wednesday evening Facebook live stream session. I'm Dr. Muhammad Azrif, and I'm a consultant clinical oncologist at Prince Court Medical Center. I'll be talking about men and cancer. I don't have any like pretty pictures kind of thing. I leave that to my colleagues later on. I'm more of a data-driven person, so I just prepared a few slides regarding the most common cancers among men within Malaysia. So this data is widely available from the Ministry of Health website, and the two references are basically the Malaysian National Cancer Registry 2012 to 2016, and also the Malaysian Cancer Survival Registry 2016. Okay, so we can see here when we break down the incidence of new cancer cases according to gender in Malaysia during this period, we find that it is true that males have the incidence of cancer among males is a little bit less compared to women, as you can see here. So out of about 100 new cancer cases a year, about 55 will be female and 44 will be male, right? So we will go through, and this seems to be consistent among the different races as well. We see that among the Malays, Chinese, and Indians, generally there are more. We can see among the incidence. So this is a female, and then the male over here. You can see among the Malays, right, a higher incidence. So the higher number means more number of cases, more number of cancer cases among the Malays, Chinese, and Indian women as compared to their counterparts, as compared to their male counterparts. And this is consistent for 2007, 2011, and 2012 to 2016 as well, right? So if you look at the most common cancers in men, we can see the number one, which is quite surprising to many men in the public, is actually colorectal cancer, almost 15%, followed by lung cancer, prostate, which is about 7.7%, lymphoma, okay, which is a cancer of the lymph glands, nasopharyngeal cancer, which is a cancer of the back of the nose, and then liver cancer. Whereas among women, 1/3 of the cancers among women is actually breast cancer. Only then is it colorectal, cervical cancer, and then lung. So if we were to kind of like take out the gender-driven cancers, so among men that would be prostate cancers, among women, breast, cervix, ovary, and womb cancer or uterine cancer, we can see that the top 3 cancers are actually similar between men and women, which is colorectal, lung cancer, and lymphoma for men. So the ones that I've highlighted with this kind of like star figure. Okay, so this is relevant because because of the kind of like the different ages at which women or men present with cancer, right? So this is a table looking at the different age profiles. The bars, the rows in yellow are men, and the ones in kind of red are women. And the x-axis here is the number of cases, and the y-axis are the ages. So if you can see here, up to the age of around 25 to 29 or so, the incidence of cancer is actually very similar among men and women. But from the age of 35 onwards, we can see there's almost double the number of women getting cancer as opposed to men, right? And this, as you can see, this continues all the way up to the age of around 65 or so, and then this is when men start to outnumber women when it comes to cancer cases, right? So consistently 7,000, 6,000, 7,000 cases in men, right? Whereas you can see it starts to kind of like drop off among women the older they get. And the reason for this really is quite interesting. It's basically how these different cancers present. Okay, so, right. Okay. So let's look at, sorry. So so this graph up here is for men, and the graph down below here is for women. The x-axis here is the different ages, and the y-axis is the incidence. Okay, so the number of cases per 100,000 population. So you can see these various lines here, and these are all color-coded to the type of cancer. So for men, colorectal cancer, lung, the blue is prostate cancer, lymphoma is green, nasopharynx is kind of like black here, okay? And whereas for women, you can see here the kind of like purple line is actually breast cancer. So you can see for women at around the age of about 35 or so, or 30 or so, you see a massive increase in the number of breast cancer cases, which significantly outpaces the other kinds of cancers, colorectal, cervix, ovary, or lung cancer, which are way down below here, you see. And for like colorectal cancer or lung cancer, they only really start to increase in numbers from the age of around 55 or so, right? So whereas for men, as you can see here, the kind of like the number of cases only really start to increase around the age of 50 or so. Okay, 55, 60, they start to increase a bit more rapidly, right? So colorectal, lung cancers, then they continue to increase up to peak around the age of 60 to 7, around 60 to 70 or so. Okay, whereas at the same age, among women, you can see all the numbers are starting to drop. So what we are seeing here is basically women in Malaysia tend to present at an earlier age, mainly with breast cancer, whereas men tend to present at a bit later age, so in their 50s, 60s or so, with lung cancer and colorectal cancer. So obviously this is due to various factors. Primarily, obviously, men do not have breasts, so it is highly unlikely that they will develop breast cancer. But for colorectal and lung cancer, these are more what we say lifestyle diseases, okay? So how you choose to lead your life, whether you smoke, whether you exercise, the kind of diet you take, the consumption of red meat, this will all determine your probability of risk of getting lung cancer or colorectal cancer. Okay. The other thing as well is in terms of colorectal, the other thing that we need to consider is, for example, the incidence of colorectal cancer, incidence of these cancers, and also the survival of these colorectal, lung, and breast cancer. So let me just give you an example to illustrate this concept. So here is a slide looking at colorectal cancer, and the top graph here are for men, bottom graph here is for women, and this is divided according to ethnic groups and the number of cases we see, right? So as you can see for men tend to get, among Malays, whether you're Malay, Chinese or Indian, you are more likely to develop colorectal cancer compared to women. Okay, so that's number one. But in terms of colorectal cancer and lung cancer, men are more likely to develop these two cancers compared to women, right? So that's the first concept to understand. The second concept to understand is, or principle when it comes to these cancers in Malaysia is, for colorectal cancer, the cases, we see more cases in stage 3 and 4 in Malaysia. Okay, so again, for this is male and female, we can see for stage 3 and 4 here, stage 4 about the latest results, about 40% of women will present in stage 4. For men, around 40% as well. Stage 3, around 30%. So we're talking about 70% of colorectal cancers in Malaysia will present in stage 3 and stage 4, whether you're male or female. This is worse in lung cancers. This same registry indicates that 90% of the lung cancers we see in Malaysia present in stage 3 and stage 4. Right now, okay, this is a key principle to understand, because our survival of these cancers is very dependent on the stage in which we present. If we present at a more advanced stage, we will have a poorer prognosis. The outcomes will be worse. So this is the colorectal cancer survival in Malaysia compared to other countries. Okay. And this is for male and female. So obviously in Western countries, Canada, US, the survival is around 50 to 60%. Right? This is 5-year survival, whereas our survival is a lot worse. Our incidence is a lot worse. Okay. Right, and this is actually the survival according to the type and gender. So certain cancers, we can see a clear difference in survival between gender, and this is thyroid cancer. We see women who present with thyroid cancers have better chance of surviving. But when we look at colorectal or lung cancer, the survival is actually very similar, right? Around 50% so. And for lung cancer, it's around 10% in 5 years. Prostate cancer is very good, 70%, but unfortunately, women don't get prostate cancer. In breast cancer, which is the most common cancer among women, 5-year survival in Malaysia is about 66%, right? And this 66% is much better than the 50% we see in colorectal cancer or the 10% that we see in lung cancer. So, how can we conclude all this? So basically, although cancer is slightly less common in men, we see more cancer cases in men over the age of 50 years. The most common cancers in men are colorectal, lung, and prostate cancers. And unfortunately, at this moment in time in Malaysia, the majority of colorectal and lung cancers present at the more advanced stage, where treatment is less successful, the risk of relapse is higher, and unfortunately, if they relapse, that usually means a stage 4, and the kind of like intent of treatment is really for control of the disease rather than a curative treatment. The the real shame about all this really, or the tragedy really, is that lung and colorectal cancers are actually very preventable. The majority of lung cancers among men is due to cigarette smoking. And most colorectal cancers, 1/3 can be prevented by living a healthy lifestyle, according to WHO, and we can reduce mortality by 1/3 by proper screening. So this is where detection of cancers at an earlier stage would mean that patients have a better chance of cure. So really, my two, if there's if the audience do not remember anything I have said and just able to remember two short sentences, really, for men, those between the age of 30 to 65 years are less likely to get cancer, but more likely to die of the cancer. But if they do get the cancer, they're more likely to die of it. And this is because the cancers they get at this age tend to be colorectal cancers or lung cancers. If the men survive to above the age of 70 without getting any cancers, then above the age of 70, they are more likely to get prostate cancer, because by this time their counterparts, the incidence of cancer among women is decreasing. But the prostate cancers that they get has much better chance of survival, in Malaysia around 70%. So they're less likely to die of cancer. Okay. Right, so I think that's the end of my presentation. Thank you.
Right. Thank you so much, Doctor. I think you've unfortunately given very jarring, scary numbers, and hopefully people pay a little bit more attention to what Dr. Azrif has pointed out this evening. Doctor, a couple of questions, and would we be able to take those questions?
Yeah, no problem.
Okay, lovely, Doctor. The first question that seems to have popped up is, in terms of screening, when do men need to start screening? Any thoughts on this, Doctor? And I mean, they haven't put down the question of what should they screen for. You mentioned it, and I think it'd be good to kind of point that out again.
Okay, so I think this is a very good question, because obviously among men, the most important cancer in kind of middle-aged men we need to watch out for is colon cancer. Okay, because this is the #1 cancer among men. So for colon cancers, there are two kinds of screening. We can either do a stool test to detect the presence of microscopic traces of blood, and this is called a fecal occult blood test. Don't let the name confuse you. It's not a blood test. It's actually a stool test to detect occult blood, okay? To see if there are traces of invisible, like to see traces of red blood cells within the stools itself. So if this is a non-invasive method, they just need to get the kit, pass motion, sample a little bit of the stool, put it into the kit, and then send it to their doctor to be sent to the lab for the test. You usually get the result in about a few days. So if the patients opt to go for this stool test, then we would advise patients to do it once a year. Men can include it as part of their normal annual health screening. More accurate method of screening is actually by doing a colonoscopy. Colonoscopy is a procedure whereby it's a more invasive procedure. So the patient will have to do it in hospital, usually by a gastroenterologist, and then they will insert a thin tube called a colonoscope up through the back passage to examine the whole colon or large bowel, large intestine. This, if it is done, should be done kind of from the age of 45 onwards, right? And same for the stool test as well, so 45 onwards. If men opt for the colonoscopy, it should be once every 10 years, provided the previous colonoscopy was normal. So for example,
Okay.
if a man decides to go at the age of 50 for his colonoscopy and it's all fine, no polyps, no signs of cancers, then his next colonoscopy will be at the age of 60. So this is kind of like proven by research, really. Either method, either the occult blood test or the colonoscopy, has been shown to reduce the mortality of cancer. So the risk of men dying of cancer by anything from 20 to 30%.
Right.
unfortunately, this colorectal screening is already part of the kind of like National Health Service in the UK, Australia, and also in the US and many countries in Europe, but it's not really it's not really offered in Malaysia. It's more of a kind of like ad hoc basis. It's not on a population-wide screening, which I think is where we are still lagging behind here.
Right. Got it, doctor. And ladies and gentlemen, just to kind of, so that was on colorectal cancer, doctor. I'm just going to
Yes.
ask you about other things that men should get screened for, but I just want to add as well, and I'm sure doctor is going to allude to that as well. We're going to start March in a couple of days, and March is Colorectal Cancer Awareness Month.
Yes.
So, hey guys, go and get your pardon my French, your shit looked at this month, perhaps. Yeah, yeah. Doctor, sorry, just to kind of get come back to you on what are the screening, doctor, that you think men should kind of actually pursue.
Okay, so obviously number one is the colorectal cancer. Okay,
Right.
so that's a primary one, especially when you're kind of hitting north of 40 years old kind of thing. You should really be thinking about this. Okay, because that is where the incidence starts to increase, age of 40 onwards. Definitely from the age of 50 onwards, men should be going for colorectal cancer screening. If you don't like the idea of someone inserting a scope up your back passage to examine the large intestine, then at least go for the stool test. Okay, and this can be done as part of the annual medical screening package. It's very easy. You pass motion as per normal. Just need to take a little bit of the stool and send it back to the doctor to send to the lab. Other kind of screening would be if a man is a heavy smoker, then we do advise to do a special kind of CT scan to screen for lung cancer. And this is kind of like once a year for the first 3 years. But this is really only for heavy smokers among men, right? So those who have smoked more than 20 cigarettes a day for kind of like more than 20 years. This is what we would advise to do, because there have been some studies out of US and Europe that shows if men go for this kind of like lung cancer screening, is able to detect lung cancer at an earlier stage. But to be honest, I don't want to send the wrong message in terms of lung cancer. The main thing for lung cancer is basically to don't smoke, right? There's no point thinking, oh, it's okay, I smoke and then I just go for my lung cancer screening at the age of 50. Smoking doesn't just cause lung cancer, it causes many other kinds of cancers, pancreatic cancer, stomach, bladder cancers, also increases your risk of heart disease and strokes. Okay, so screening for lung cancer with a CT scan will only detect, give you a bit better chance of detecting lung cancer at earlier stage, will not prevent you from getting all these other cancers. Okay, so screening for screening lung cancer, my advice would be stop smoking, right? So for prostate cancers, that is the top 5 cancers among men. Prostate cancers, basically men can go for a blood test to check their PSA. PSA is a prostate-specific antigen. This is really the only cancer by which you can screen for by using a blood test. Really, one study in US where men tend to do a lot of PSA screenings did not show any benefit, but a study in Europe showed that if men go for PSA screening, they have a lower chance of dying of prostate cancers. Okay, and this is really from the age of 50 onwards. Most men, if they go for their annual medical checkup, with this, it includes a blood test. It will usually include a PSA test as well. Yeah. So 3 things: the colorectal cancer screening has been established. Men, regardless smokers or non-smokers, should go for colorectal cancer screening. This is kind of from the age of 45 onwards. Lung cancer, stop smoking. Prostate cancers, PSA once a year from the age of 50, 55 onwards. Okay, but prostate cancers usually tends to affect men over the age of 65. So I wouldn't be too kind of like worried about getting prostate cancer at a young age, really, to be honest.
Right. Well, do. Thank you so much, Doctor. I think that was very like kind of accurate age-specific screening recommendations. Doctor, there's two more questions, if
Okay.
you're okay to take.
Yep.
One is about how about a secondary smoker? Is the risk the same as a primary smoker to get lung cancer?
So the risk is much, much lower if you're a secondary smoker. And we find that this seems to be more prevalent among women, this exposure to secondhand smoke. Because I think most men, if they are kind of out with friends in a social environment, if their friends are smoking, to be honest, they will usually start smoking as well, right? Whereas among women, if they go out, if, for example, their husband smoke, women do not usually smoke, right? So women are exposed to passive smoking. Passive smoking increases the risk of lung cancer by around 30%. It is one of the most common reasons why never smokers develop lung cancer, right? And this is what we see among women in Malaysia, right? Even in Malaysia, a lot of the women who get lung cancer usually are never smokers, but they may have been exposed to passive smoking or pollution, etc., right? And then they are at higher risk of getting lung cancers, right? It is not that common that I see a man who has never smoked developing lung cancer, to be honest. It's not that common.
Right. Got it, doctor. And there's one last question on, doctor, are there any reasons why the government can't just mandate that when men reach the age of 50, you have to do cancer screening? Maybe this can be tied to insurance or EPF or SOXO. Any kind of thoughts on this, doctor?
The government has had pilot studies with basically the FOBT really,
Mhm.
rather than colonoscopies. For colonoscopies in Malaysia, to be honest, is quite difficult to roll out. Okay, one thing is because the colonoscopies are usually done in a hospital setting. The way it's set up usually is doctors. In countries where they do colonoscopy screenings, they usually train up nurses, specialist nurses, just to do normal screening colonoscopy. So if there's anything more where they have to do biopsies or remove polyps and stuff, then usually they call in the doctor. So the doctor is kind of like on call when the nurses are doing the endoscopy, the colonoscopies, right? Colonoscopies does require, there's a bit more of a steep learning curve. The FOBT is something that is more easily done. Our previous government, the previous health minister, Datuk Dr. Zulkifli, he was advocating incorporating the FOBT test in the PERCA B40 and all this, right? But unfortunately, with shall we say, political changes that happened last year, this was kind of put on the shelf, right? Hopefully, once things are a bit more stable after the pandemic, we can have this discussion again. Right, so that's from a kind of like government point of view. The insurances, there are some, to be honest, I probably get sued by the insurance companies or get NCSM probably get emails or complaint. Okay, the insurances in Malaysia, to be honest, they're a bit behind the times, right? I would say 5 to 10 years behind the times, really, in terms of their kind of like their coverage and what they offer. There's certain insurances like AIA, they are kind of like premium package. They try to promote screening and healthy living and things, right? But most of the insurances really are more kind of like geared for treatment, hospitalization, treatment kind of thing, rather than trying to encourage patients to go for screening, FOBT and things. But obviously, this is something that they should incorporate, especially when it comes to their more premium packages. They really should look into this. The problem is, though, this will mean a higher premium to their customers, to their clients. Yeah.
Yep.
Because the insurance companies will not bear the cost of the test.
Right.
Their commission structure as well for the private medical insurances are quite high. I think most people will be surprised to hear that 50% of the commissions, premiums they pay per month for the first 2 years goes to the agent rather than actually to your insurance package itself. And the commissions go on for like 6 to 7 years, right? So hopefully with e-commerce, digitalization and things, that will help to bring the prices down. We need more competition from the insurance point of view, really. The insurances are still very high.
Right. That's absolutely true, doctor. I think we all just got blocked from all the insurance channels.
Yeah.
Yeah. No, I'm kidding. But yeah, thank you so much, doctor. I think that really kind of gives us a bit of a better perspective on screening in terms of like why this big picture we can't get it to take off. So as we close this session, doctor, I was going to ask you to kind of any takeaways that you can give or share with us for this evening.
So I think number one obviously is I don't want to paint a bleak picture. Okay, colorectal cancer, lung cancers are very common cancers among men. Okay, we have shown for breast cancers, if you have concerted campaigns, awareness programs, right? The kind of the fear of breast cancer can be easily dealt with or reduced among women. We need to get over the stigma of talking about our stools and bowel habits and rectal bleeding and things. Okay, we need to encourage our population to lead a healthy lifestyle. These cancers, the lung cancers and colorectal cancers, to be honest, they are preventable, very much preventable. We should be able to do a much better job at detecting it at an earlier stage. I think the public, government, private sector, insurances, I think we need to come together to try and work towards a solution. We cannot rely on the government to do everything, right? I think we do need to play our part as well. And I think this is where collaboration between MOS, NCSM, MOH, insurance companies, I think is vital to be able to move things forward. The pandemic past couple of years, last year and this year, is kind of put everything into a bit of a stasis. Hopefully, though, once the vaccination rolls out, things will get back to normal later on in the year, and then we can plan for a better future for ourselves and our families and children over the next few years as well.
Lovely. Thank you so much,
Thank you
Doctor,
very much.
for that message of hope. A very good evening as well, ladies and gentlemen. That was Dr. Muhammad Azraif, Consultant Clinical Oncologist, Prince Court Medical Center, and President of the Malaysian Oncological Society. Thank you so much, Doctor. We'll see you soon.
All right. Thank you very much. Okay, bye-bye. Have a good evening.
Next on, ladies and gentlemen, this evening we are partnered with Prince Court Medical Center to bring you their esteemed clinicians, some of their highly acclaimed doctors to speak with us. And first off, just now we had Consultant Clinical Oncologist, Dr. Muhammad Azraif. Now, second up, and today we're talking all about men, and for the gentlemen, I think the next one is very, very kind of close to the heart, or maybe close to slightly a bit lower. And for that, we have with us Dr. Goh Eng Hong. Dr. Goh Eng Hong is a consultant urologist who is with Prince Court Medical Center. And this evening, Dr. Goh is going to speak to us about slightly a little more insights on what Dr. Azraif was mentioning about just now, which was the PSA, this three little magic letters. Good evening, Dr. Goh. Thank you so much for joining us.
Hello, Dr. Marley. Good evening. Can you hear me?
Yes, I can, Doctor. Thank you so much for taking your time off this evening to join us and share with our colleagues a little bit about PSA. Dr. Goh, before we kind of kick in, we always have one funny question. And we wanted to kind of maybe touch base with you on why urology?
Why urology? Well, I think a lot of reasons behind this. One of the things is my interest in the surgery, and then during my years in the surgery training, I find urology to be particularly more interesting, and then with my intense interest in urology, that's why I pick up this specialty. Yeah.
Lovely, Doctor.
Mm.
Doctor, so this evening, you're going to speak to us a little bit about one of the most talked about cancers in men, prostate cancer, yeah? And one of the biggest problems, Doctor, I think is everyone's a little worried about their prostate as they get older. And what we do is, I think even family members of mine included, what we do is we run and go and get a medical checkup. And inside there, we always tick a box which says, shall we order add-on PSA? So you add on your PSA, comes back a bit funny, and then we all don't know what to do. So maybe, Doctor, I think we need to ask you to kind of give us a little bit more insight on this. Over to you, Doctor. I'm going to share the slides from my end, and then please tell me when you want to switch the slides.
Yeah.
We do that straight away. And there you go, Doctor. Are you able to see that, Doctor?
Yes, I could see it. Yes.
Okay, lovely, Doctor. Then whenever.
Okay, right. So sorry for the inconvenience. Yeah. So when it comes to prostate cancer, clearly, the first thing that we ever encounter is a rise in PSA. All right. So and then when it's high, what are we going to do? Causing a lot of confusion. Okay. So before I move further, I just like to describe a little more about prostate and what is it exactly. Next slide, please. Yeah, so what is prostate? So prostate is an organ which is only found among the men. So you can see that on the diagrams, we have bladder, and then below the bladder, there's a urine tube in which the urine passes through. So just below the bladder, there's one organ that surround the urine passage, and that organ is prostate. It's just like a donut that are wrapping up the urine tract. Okay, so it is actually part of the reproductive organ, part of the sperm production. Okay, so I know our topic today is about prostate cancer, but what I want to highlight is that actually, most of the time when we see someone with prostate problem, usually it is not prostate cancer, but it is the other thing. For example, enlargement of the prostate, or because of the prostate inflammation, so on and so forth. Okay, so unfortunately, all the things they could coexist, right? So in terms of prostate cancer, who gets it? Well, it is mainly a cancer for the elderly population. All right, we don't usually see it among the younger ones. Usually, it exists among the more elderly population. All right, so it is just a cancer that occurs in the prostate. All right, not usually in the middle part, but usually more of the external part of the prostate. All right, next please. Yeah, so who are the people who are at risk of getting cancer? Clearly, it is cancer among the men, so among men who are aged about 60s and above. So rising incidence with age, right? Who are at risk? In general, the incidence is less among the Asian population, okay? But still, the incidence is rising, I think because of the change in our diet and the change in lifestyle. All right, and another thing is that the presence of family history. So if the history of cancer in the family, for example, cancer of the prostate or breast cancer, then there's the increased risk of cancer among those in the family. All right, next please. Okay, so how does prostate cancer present? Unfortunately, this cancer, it is silent almost all the time. So it might present with a change in urine pattern, but usually when present with a change in urine pattern, it is because of the other coexisting problem in the prostate, for example, enlargement prostate, or enlarged prostate, or because of prostatitis, like inflammation of prostate. All right, and then there are also potentially a man could present with the blood, the sperm, but this is not actually very common. As a matter of fact, when someone presents with blood and sperm, usually the cause is because of infection or rarely because of trauma. However, when the cancer is late, for example, when the cancer has advanced beyond the organ, migrating to other organs, for example, the liver, the lung, or the bones, then the patient can present with a pain in the bone, weakness, lethargy, difficult breathing, or in general, not feeling well. Okay, so from history, we probably don't get much, But when we examine the patient, for example, when we put our finger inside the patient's back passage, so putting the finger in the back passage, not just to feel for any lump in the rectum for the colon cancer, but also when you put a finger inside the back passage, you could also have a feel at the prostate. So when the prostate is normal, you might just feel smooth and a normal consistency. However, if the prostate is felt to be quite hard, lumpy, nodular, then there's a high suspicion that a patient might have a cancer in the prostate. Okay, next slide, please. Yeah, so the thing is, PSA test. Is this test reliable? Well, I have to say that PSA test, it is actually not disease specific, but it is organ specific. All right, so therefore, when there's a rise in PSA, there actually a lot of things can cause a rise in PSA. So, but when it's a rise in PSA, it doesn't always mean that there is cancer prostate. As a matter of fact, when there's a rise in PSA, usually there are other causes, right, which is clearly not cancer. Okay, for example, what can cause a rise in PSA? Enlarged prostate. All right, number one, when the prostate is huge, the PSA could rise also. Second thing is that when the prostate is infected or irritated or inflamed for whatever reason, there could be a rise in PSA also. Thirdly, of course, prostate cancer. Another one is recent history of a sexual activity, like ejaculation, okay? And also another thing is bicycle riding, because of the saddle pressing on the perineum, the private part area. All these could cause a rise in the PSA. So some of these causes, the rise can be persistent, but some of the rise can be transient, maybe a couple of days, 1 or 2 weeks. So therefore, this is the reason why when someone has the intention to go for a PSA test, if I have a chance, I would advise the patient, to abstain from the activity, for example, bicycle riding, and then the sexuality for a couple of days before they go for a test. You're going to ask me how many days, how many weeks? It is hard because there's a lot of background noise when it comes to PSA testing. As you can see, there's so many things can cause a rise in PSA. So in general, I just tell the patient, just absent for a while. And if there's a rise, and if the rise is not too high, there's a good chance that it could just repeat. And then, quite a few times, the PSA just drop back to normal. Okay, so you can see that why there's a high incidence of having a rise in PSA, because usually men would go for a PSA test as part of their medical screening around age 40s or 50s. Well, and it is also around this age that a man would get an enlarged prostate. Let's say 50-year-old man, 50% get a large prostate. And then because prostate enlargement and prostate infection, these are things that can coexist. All right, and then because the age is common among 50s for large prostate, men go for screening around at age 50s, and men usually go for more healthy lifestyle, for example, exercise around this time. So, and then usually biker is one of the more gentle exercise. So you can see that, sometimes the rise in PSA, truthfully, a lot of times it's just about reassurance first, as long as the PSA rise is not too high. This is number one, doing right things at the right time. Two is that you can see that the slide also show that when there's a rise in PSA, usually the lab will show that the normal values is until 4. But I want to show to you that the number of 4 is just to show you the 4 is just valid for men whose age is like 60s to about 70. As a matter of fact, the normal value differs for different race. For us Asian, the normal value is actually lower, and as a man gets older, the normal value gets higher. So therefore, let's say a man at 43 years old, you go for a screening check. If the PSA is 2.3, well, it looks normal for the supposedly normal value, but actually 2.3 is a bit high for that age group. Okay, all right, so that's why there's a lot of variation when it comes to PSA test. All right, next slide, please. So besides PSA, what are the other things that we could do? Well, I had to say that, there are a lot of things we could do, but really and truly, we should start with simple things first. For example, do a PSA at the right time. And then the next thing we do a digital rectal exam. That means put a finger inside the feel for the prostate. Of course, the other thing that we can do in the simple way is that we do an ultrasound. It's like putting a probe into the back passage and look at the prostate. Okay, so sometimes when it's obvious, you might see a lump in the prostate, but this is not an assessment which is very accurate. Of course, the other thing that we can do as a part of testing is like going for the MRI, CT scan, and bone scan. But really and truly, CT scan and bone scan, they are not valuable in terms of diagnosis. They are more meaningful when someone has got a confirmed cancer. It is mainly meant for staging to know the extent of disease. MRI used to be having a role in the later stage, but nowadays there's increasing role of having MRI quite upfront, not as a first role, but probably as a part of assessment before or just after biopsy. It depends what the results say. MRI, and it's not a usual MRI; it's just MRI which is specifically looking at the prostate, and usually call it the multi-parametric MRI. What kind of biopsy? Well, biopsy means that to put a needle inside the prostate and to get tissue for testing. So when it comes to MRI and biopsy, well, the role can sort of switch. So I think it can go either way. Depends on the clinical situations. All right. So next slide, please. Yeah. So screening. So probably everybody is aware what is screening, but I thought just a recap, what is the definition of screening? Screening basically, you look for a disease when there's still no symptom. That means that a disease that is basically silent, to detect the disease when it's still very much at the early stage. Because detected early, potentially the outcome is more favorable. However, when it comes to prostate cancer, the situation is controversial at best, because we are talking about benefit and also need to consider the risk, the side effects, the outcome, the toxicity, a lot of things to consider. So these, the benefit and the risk, the issue that we need to discuss, it starts at the very early towards the very end. If you want to do a biopsy, should you go for it? Should get for treatment? Should go for it, because even going for a biopsy, there's risk. For example, putting a needle inside, there's risk of bleeding and the risk of infection, of course, pain as well. So, ladies and gentlemen, do you need it? That's the question. And who needs it? Okay, next question. Next slide, please. So because of this, there's a lot of guideline. I just pick one. Well, basically, this is the guideline from the AA, the American Urology Association 2013. Who is the recommended one going for a screening test for PSA? In general, there's no role to go for a PSA test for anyone whose age below 40 years old. For 40 to 55 years old, who go for this test? Those who are at higher risk. That means that those who has a family history, then they could consider going for a screen test of prostate cancer at this age. Otherwise, the screening test for prostate cancer starts from 55 to about 70 years old. Even then, it is after shared decision making to discuss with the doctor whether to go ahead. In general, it is not recommended for anyone whose age is above 70 years old, or anyone who already has many medical illness in which the life expectancy is not expected to be more than 10 to 15 years old. However, age is just a numbers. If the patient is still very healthy, even at 75 years old, and patient is really keen, I reckon that, as long as the patient understand what is the risk, what is the benefit, I let the patient make a decision whether they go for it or not. Okay, next slide, please. Next slide. Yeah, so the question is, even if there is a cancer detected, do you need treatment? I think when it comes to cancer prostate, the concept of mention is quite new and potentially hard to accept, hard to swallow for quite a lot of patients. because we always being told that when someone got a cancer, treatment. But evolving evidence saying that when someone has a cancer prostate, depends on the situation. Not all cases, if agreeable by the patient, require treatment. So this because when someone got cancer, one needs to remember that cancer prostate is not something which is cancer. That's it. It is cancer prostate is something which has a lot of variability in terms of severity and aggressiveness. So therefore, the treatment got to be tailor-made for each patient. And for someone, to decide what is the next step forward, we have to look at a lot of things. For example, look at the disease, one, and look at the patient. Patient is about what is the patient aspiration, the background medical condition, all right? And then to look at disease, look at the PSA score. I mean, an MRI scan, look at how aggressive the disease, and look at the Gleason score. How aggressive is how extensive is the cancer? So having all these information about the extent disease and the patient's concurrent medical condition, then one can decide, whether to go ahead or not to go ahead. So as a matter of fact, close monitoring at this point in time is actually a valid option. And one needs to remember that not doing anything is not considered not treatment. The treatment is monitoring, okay, and reassurance. Okay, so as a matter of fact, about 45% of the patients, they are actually suitable for this situation. Some patients, they are just not suitable because they have a lot of comorbidity. Some patients, they are fundamentally not necessary because why? The cancer is just too low risk, too low burden. So they could just wait because I'm quite sure that everyone knows that treatment comes with side effects, okay, and toxicity and complications. Okay, so the slide is to show you, or in terms of close monitoring, we have two types: active surveillance and watchful waiting. So active surveillance is fundamentally for those who have very low disease burden. The aim is still to give a cure for the patient, but to do the right things at the right time. Okay. However, patient who was under active surveillance, they have protocol. Like periodically go and see a doctor, repeating the PSA, and then consider to repeat a biopsy. All right. However, any point in time when they change the characters or patient feel anxious about it, then that patient could consider going for an active management. That means go for treatment like surgery or radiotherapy. However, some patient who is already quite aged, having a few comorbidity, potentially not really aiming to go for a cure, but rather going for comfort care. So in that aim is looking at like palliative intent. So patient studies, there's not really a clear predefined schedule. So it's just like still monitor, but only do it when patient consider they want to go for it. So basically this is just what we can do for a patient, selecting the right patient at the right time. Of course, patient need to understand the risk and benefit and agreeable for being monitored. Okay, yeah. So next slide, please. Yeah. So therefore, as a summary, when you come to prostate cancer, one needs to remember that if there's a rise in PSA, hold on, stay calm. There's a lot of background noise in PSA. So the right thing is that just discuss, and potentially there's still room just to repeat the level sometime later on. And then even to go for the next step forward, you can still discuss with the health provider, what's in there and go for it. All right, that basically conclude my talk. Thanks. Okay.
Thanks so much, Doctor. I think very important insights that you shared with us today. And I think one of the main things that you mentioned, and I think this is quite a common problem. A lot of people look at their lab results, and when it's not flagged or, marked red with the PSA, they immediately feel that, hey, everything's good, just carry on as normal, without realizing that it's actually very age specific, Doctor. And I think so that's one of the important points, ladies and gentlemen, that Dr. Go kind of highlighted this evening. And also, I think very importantly, Dr. Go also kind of put forward management in terms of what do you do when you actually have a diagnosis of prostate cancer. And it doesn't necessarily mean that everything needs to be cut straight away and then hit the ground running. I think that's in terms of prostate cancer is really, I think, isn't it one of the more unique cancers in that sense, Doctor?
Yeah.
Yeah, because this is the only one that really you look at having this idea of active surveillance.
Well, I would say this is one of the pioneer disease that go for monitoring. What comes next is like kidney cancer. We call it the SRM, small renal mass. Yeah, so sometimes when it's still small, wait.
Right. Got it.
Yeah.
Okay.
Yeah.
Well, Doctor. Doctor,
Yeah.
I wanted to check with you. Are we able to take some questions, Doctor?
Sure. Yeah.
Okay,
Yeah.
lovely. There's
Yeah.
first question, Doctor, seems to be from one of our viewers on what is the questions are actually in Bahasa. I'll just translate to English and then what is the understanding of the use of PSA in the cancer journey, like in when you have prostate cancer stage 4, what do we use PSA for at that point in time?
Yeah, I mean the PSA, the uses for PSA in cancer is widely variable for the entire journey. For detection, for deciding the prognosis, that means to decide the treatment, and also as a form of monitoring. So let's say if you don't do anything, if the PSA rises, that means that the disease is progressing. If you do something, if the PSA is coming down, basically in general, it means good thing. The disease is getting under control. If you go for treatment, if the PSA still keep rising, you know that you're losing the battle. Yeah. Fundamentally, it is just what PSA is trying to tell. Yeah.
Right. Oh, lovely.
Yeah.
So really, Dr. Go is saying that the PSA functions as a barometer to kind of gauge where you are in terms of treatment, Doctor.
Yeah.
Right.
Yeah.
Okay. Doctor, this is a naughty question, I think. Is there a role in active sexual activity in reducing the risk of prostate cancer?
Well, how could I put it nicely? I can't remember in exact detail. I have read, and then I think in terms of active sexual life is sort of I can't remember the exact year, but active sexuality, having frequent ejaculation is same sort of like preventive. Yeah, I wouldn't say preventive, but sort of like lower risk.
Reduces the risk.
Yeah.
Yep. So take of that what you will. If it helps you to make a better decision, member of the audience, please go ahead. Always better more than less in this case. Okay.
Sure.
Doctor, then maybe one more, is it okay for one more question, Doctor?
Sure.
Okay, lovely, Doctor. So this one is a question on, will it be always better to have a MRI first, multiparametric MRI first before biopsy, so that the multiparametric MRI can then be used to guide the biopsy?
Yeah, if you ask me, I mean, in general, there's no clear guide as yet what to do. But if you ask me, I tend nowadays to go for the MRI first before I put the patient for a biopsy. Yeah, this is what I would do. Yeah.
Okay, lovely, Doctor. There's also another question, Doctor. Why do we need to do an MRI and a CT scan from what Doctor was saying earlier for prostate cancer?
So the MRI is mainly to look just at the prostate, whether it is inside or whether it has gone just outside the prostate. The MRI might pick up the lymph nodes at the neighborhood. That's it. However, MRI is not so good in terms of looking how far the disease has gone to. That is the role of CT scan and bone scan. So CT scan to detect whether it has gone to the distant district, for example, the liver, the lung, and bone scan to look at whether it has gone to the bone. Yeah.
Right.
This is the reason. Yeah.
Okay, will do,
Yeah.
doctor.
Yeah.
Thank you so much, doctor, for
Oh,
such an interesting set of insights, and I think
yeah.
very helpful,
Yeah.
hopefully to our viewers this evening. As we round up this session,
Yeah.
could I invite doctor to maybe leave us with one or two takeaways, doctor?
Well, because I practice yogi and then cancer prostate clearly is attention day. What we're going to say is that uh, one needs to remember that cancer prostate is not the entire thing. Even things like prostatitis, even things like BPH can cause havoc in a man's life. Cancer prostate clearly not always, but it can be life-threatening. But having a prostate issue, it can be life-changing. So therefore, for example, prostatitis sometimes happen because of infection, and that can cause a lot of trouble for men, affecting their quality of life. So therefore, I advise that not just looking at cancer, sometimes you just have to live things in a balanced way, healthy lifestyle, so that it's not just for cancer prevention, it is fundamentally also for a life which is rewarding and meaningful. Because not just cancer, other things can also cause a havoc in somebody's life, yeah, not life-threatening, but life-changing, yeah.
Right.
Yeah,
Okay.
yeah,
With those words, we'd like to thank Dr.
yeah,
Goh Eng Hong today for his invaluable insights. Thank you very much, Doctor,
yeah,
and have a good evening. Dr. Goh Eng Hong, ladies and gentlemen,
yeah,
who is a consultant urologist at Prince Court Medical Center.
yeah,
Thank you,
yeah,
Doctor.
yeah. Thanks a lot. Yeah, thanks. Have a good evening. Bye.
Good evening.
Bye. Bye.
Ladies and gentlemen, we are at the second segment, which is coming to an end on this evening's Cancer and I. And this session is brought to us together with our partner, Prince Court Medical Center, and of course, not forgetting our primary partner, Roche Pharma Diagnostics and Shared Services, who have been invaluable to kind of put together this series of sessions. Now, next up, we will have, and this evening, ladies and gentlemen, we are discussing men. And I think Dr. Muhammad Azrif, consultant clinical oncologist, came on this evening to kind of point out to us the problems with men in terms of cancer. And one of the things that he was talking about was about prostate cancer. And I think he had another very important set of issues with colorectal cancer as well. So next month is colorectal cancer and Cancer Awareness Month. So go ahead and do something for that. And we're getting someone in this evening, and I'm actually very excited to have Dr. Muhammad Faisal Jabbar. Actually, I call him Prof. Faisal because I don't know whether Prof. Faisal remembers, but I was his houseman about 100 years ago. And
Hello,
yeah, hi, Prof. Good evening. Out of Hospital Kuala Lumpur, and it's a privilege and an honor to have us Prof. Faisal with us this evening. Prof. Faisal is a consultant surgeon, and Prof. Faisal has a long career in both academia and professional work as a surgeon as well. He's been very instrumental mentoring many surgeons across the board here in Malaysia. So, Prof, I've never asked you this question. Why surgery, though?
Well, ever since I joined medical school, I thought surgery would be something for me because I like to work with my hands. It's something which is both vocational as well as practical and physical, and you can still practice medicine while doing surgery. And with surgery, there's also the component of medicine which you will have to impart on your patients for their perioperative care. And therefore, I think it's the best of both worlds. You get to see medicine, you also get to see surgery.
Right. Lovely. Thank you, Prof. And always very inspiring for us to kind of have you teach and all that. So right off the bat, I'm going to pass this over to Prof and let Prof go through the session in the interest of time, and then we can take some questions together. Prof,
Sure.
over to you.
Thank you very much. Shall I share the screen now?
Yes, Prof. Please go ahead.
Assalamualaikum and good evening. My name is Dr. Muhammad Faisal bin Jabbar. I've been in practice for well over 20 years. Yeah, I first returned to Malaysia in the year 1998 as a consultant surgeon in general surgery. And since the topic today is about, is it showing at all?
Yes, it is, Prof. Maybe you want to put out the to slideshow version.
I can't see actually. One minute. I'm sorry about this. Slideshow. Sorry for the delay. Okay.
Okay.
There we go. There we go. So the topic given to me is about first cut and the role of surgery in the role of surgery for cancers. Let me just point out what a general surgeon does, and I would like to just go on a lighter note as compared to my previous two speakers who've actually paved the way for me to actually show you all this. And forget about the goriness of the pictures, but it does tell you, a picture does tell 1,000 words, yeah? And I will go from an anti-clockwise, in a clockwise fashion as to what we normally do. And this is what I've been doing in the last 2 to 3 weeks. Yeah. So the first photo over here, the top I put at 12 o'clock from my own photo, is a picture of an image taken from a TAMIS, which is transanal minimally invasive surgery for a patient who has locally a lesion in the rectum, which we're not sure of the nature of. The first initial biopsy came back as severe dysplastic lesion, then it came back as SRUS, and therefore we embarked on a minimally invasive surgery to remove the lesion in its entirety and to close that hole primarily as well afterwards with special sutures. So this is the way technology helps you in removing this lesion alone. Yeah, in the past we might have to embark on a much more invasive surgery and we might end up having to have a colostomy. Then we move along to the second photo, which is a lady who came in repeatedly to see gastroenterologists, physicians, surgeons, and has had colonoscopy and upper GI surgery for a non-specific recurrent abdominal pain. Yeah, and it was not diagnosed at colonoscopy, not diagnosed at OGD, not diagnosed on CT scan. And this lady, the only telltale symptom is that she never had any children. Yeah, and then eventually she developed acute intestinal obstruction, for which we had to go in to do a laparotomy, and lo and behold, this was found. So surprisingly, it was missed at more significant imaging, such as CT scan. And what she has is a very rare small bowel tumor. This was believed, if I'm not mistaken, this was a small bowel lymphoma. And this lady has had this removed in its entirety, and now she's being considered for chemotherapy. The next slide, the next picture down is in that pot is an ovarian tumor. You know that we surgeons do not operate on our own. Yeah. So this was a request by the gynecologist almost always when they perform surgery for the ovary. The ovarian cancer is such that it can spread and involve the rectum, the colon, the bladder, the ureter. Yeah, and we tend to go in together. Yeah, so this is a successful operation for which we remove the uterus and both ovaries and the whole tumor in its entirety, plus significant lymphadenectomy, and without injuring any other structures in the process. As we go down to the first set of CT scans I want to show you is a nice conundrum, and this particular gentleman presented with acute small bowel obstruction also, and because we were not sure as to what the nature of this issue is, and he's fairly elderly, we perform a CT scan of the abdomen before we go in, and it showed surprisingly a lesion in the rectum as well as a lesion in the cecum. The cecum is the part of the colon quite the nearest to the appendix, and the rectum is a part of the colorectum which is nearest to the anus. So he has two primary cancers, one very much to the right, the other very much to the left and quite close to the anus. So what do we do upon going in? That's one of the things which is what I'm trying to impart is that it's quite useful to get some idea as to what you will be doing before going into a patient. Of course, you can simply open up and perform a laparotomy, but if you are not prepared, you might not be doing the right thing for the patient. In this case, this turned out to be somebody with a familial adenomatous polyposis, and we had to perform a subtotal colectomy with a primary ileoanal anastomosis, yeah, with a defunctioning stoma, and the patient made a good recovery. Next photo down is the photo of the one on the bottom left side on your screen is a lady age 27 with a rather low rectal cancer. This lady has had when you find rectal cancers, the biology is slightly different, and normally we tend to offer them chemotherapy first when they are young. The reason being, if the cancer can be downstaged, we can preserve the sphincter, we can perhaps avoid them getting radiation enteritis with chemotherapy, with radiotherapy later, following surgery, when radiotherapy doesn't really work after the cancer has been removed. So this lady has had some partial response to the chemoradiotherapy. People like Dr. Azref gives the chemoradiotherapy, by the way. Yeah, and then because of this, she managed to preserve the sphincter. We managed to perform a coloanal anastomosis. She had to live with the stoma for a while, and following that, being given adjuvant, which is post-operative chemotherapy. And she should be able to get the stoma closed back up again in a few months. Yeah, hopefully restoring the continuity of a bowel habit. And the last set of CT scan on the top left-hand corner is a lady whom I operated on last Monday, 2 days ago. Now, this lady presented with acute left-sided bowel obstruction. As you can see, there's a very large mass in the bottom left-hand corner of the sigmoid tumor. Just believe me, it's there. The main problem with this is that she also has a very large collection of metastatic lymph nodes in the proximal part, the upper part, where the lymph nodes drain back into the body. Yeah, so this implies that the possibility of the ureter, the tube which drains urine from the kidney into the bladder might be in close proximity. In fact, at surgery, it was found to be stuck to the tumor, and thank God we managed to get somebody like Dr. Goh Eng Hong to put in a stent beforehand, and we could palpate the ureter in its entirety and preserve the ureter as well as remove the tumor in en bloc as one. Next slide, please. So this slide is just to show you what I do on a day-to-day basis. So surgery is not just about cutting people up. It's also about planning. It's also about teamwork. It's also about teaching. It's also about getting research and grants so that we can actually teach the next generation as to what to do and how to do things. Let's just start with the top left-hand corner, which are the group during you can see having a meeting. So that is a multidisciplinary meeting discussing about cancer patients. In this case, not just colorectal surgery, but I also operate on people with breast cancers and thyroid cancers and gastric cancers and esophageal cancers, and to persuade the oncologists and the radiologists to give us the best image and the best modality of preoperative imaging, preoperative care, preoperative management, the possibility of giving them chemotherapy and radiotherapy before surgery, such as with the rectal cancer just now, or especially in the case of esophageal cancer also, and also to discuss our findings after surgery and of the pathology that the pathology report that we get from the pathologist, so that we can advise the patient to undergo further chemotherapy. So the MDT is very important, really. The middle picture is about us teaching future surgeons, our own colleagues, nursing staff, as well as the general public, as to the importance and the awareness of cancers. We tend to do things by the book, all evidence-based, and I would like to say that practically what we do is what is practiced elsewhere around the world, in KL as well as in other centers of excellence. You can see a photo of us over there, happily taking a photo together after a successful operation. Yeah, we know that we are serious, but we do take the lighter side of life as well. And the next two photos down below is what we tend to show them during seminars and conferences as to what the latest things are. The ideas behind what we do, why we do, how we do things in terms of extent of resection, the surgical dose, if you like, and what we do if we were to find and to create an algorithm of care so that any particular person in the team, whether it's in public or private, understands what we do and will do the right thing for the patient always. The last photo on the left is a photo of a gentleman who's having his stoma back change, and this is also taught by the senior stoma care nurse to the nurses, as well as to be supervised by housemen and medical officers, so that they know what to do. And this information is also quite important for the carers, so they know what to do once they get home. Yeah, this is somebody who's had an ultra low and anterior resection. You can see the dressings on the abdomen 1, 2, 3, 4, where the wounds for the instruments are to transgress with the abdominal cavity. So the next slide is basically the questions which you gave me to inform the audience as to why, what general surgeons do, really, what do we do for cancers. Yeah, surgery is still, why surgery is still one of the most important modalities in cancer management. Well, if you think about general surgical cancers, particularly colorectal cancer, which Dr. Ashraf mentioned just now, breast cancer and colorectal cancers alone together comprise about 50% of all cancers altogether in this country. Approximately almost 30% are breast cancers, almost 20% are colorectal cancers. So together, we tend to do the most number of cases for the general population. Of course, there are many general surgical units. We can't really rely on one hospital to do all that. Yeah, so we have thousands of cases per year, particularly those with breast cancers, followed by colorectal cancers. And these solid cancers, the treatment is removal of the cancer. Yeah, removal of the cancer plus the adjoining draining lymph node, because that's where the cancers will spread to before they spread to the rest of the body. So solid cancers require solid treatment also, physical treatment, removal of the cancer, the adequate surgical dose, and that's only possible if once you have staged the cancer. This cancer has to be, you have to stage the cancer with the stage 1, stage 2, stage 3, stage 4, because sometimes it's not appropriate to perform the surgery. Yeah, and Mr. Morali also wants me to tell you about how we think, how we make decisions, how we make a decision to perform diagnostic decisions, management decisions, operative decisions, how we think while we're performing the operation. What do we say to patients after the surgery in clinic when we tell them and break the bad news about the cancers and all that? What do we do to them on follow-up? What tests do we do for them also? How do we engage our own staff, our own trainees, our own colleagues, our own family even, as well as the general population, as to how surgeons work. Yeah. And with that, I will give you, that was the idea of giving you the first 2 slides on showing you what I've been doing this last couple of weeks. Yeah, and we are at the forefront of informing, of creating public awareness of cancer. Of course, this is a role by the Ministry of Health, also by institutions like Prince Court Medical Center, academic institutions such as HUKM or University Malaya or UPM, where I also practice, and for us to also be actively involved in terms of reading up, yeah, knowing about the evidence behind the treatment that we give, yeah, keeping abreast with research, with training, with new technologies, with new perspectives in terms of cancer management, in terms of both diagnostic as well as therapeutic opportunities, as well as in the prognosis of the cancers themselves. Yeah, so we have a lot of work to do with cancer, and on average, approximately 10 to 15% of our work is about cancer, and in some institutions even higher than that, because they super specialize in doing cancer work. Yeah, Putrajaya, for example, the breast surgeons, some of them just want to do breast cancers alone, and they tend to be very good at it. Yeah, in our unit, we split our team to breast and endocrine, as well as colorectal, as well as hepatobiliary, and then the other special, as well as vascular. And all these people, yeah, they contribute towards the management of cancers in general. Yeah, so the general surgical cancers are solid cancers of the abdomen, breast, and endocrine glands, particularly breast and colorectal, but also other cancers which I've spoken about. Yeah, we cannot work on our own. Yeah, we need anesthetists. We also need our other surgical colleagues from other subspecialties, such as with Dr. Go, but particularly with certain cancers. So the pelvis is the realm of the general surgeon, the gynecologist, and the urologist, and not infrequently the cancers tend to involve the organs which belong to the other subspecialties. So gynecologists, for example, their cancers, their cervical cancers, their ovarian cancers, their uterine cancers can affect regions fairly close to the ureter, which the urologist might help when they perform their dissection, or their cancers can get stuck to the colon and rectum, yeah, for which they require our expertise in terms of dissecting the correct plane, or to even resect the tissue if it's too involved, and to guide them and to work together for the betterment of the patient in terms of having to, whether or not we have to give them a stoma. Yeah, so our work tends to overlap. Yeah, with the thorax, for example, I might have to work with a thoracic surgeon when we perform an esophagectomy, and with the ENT surgeon for a PLO, pharyngolaryngeal esophagectomy, with very difficult cancers, and sometimes even with plastic surgeons for a free tissue transfer, jejunal flap transfer, when the tissue isn't quite enough for a primary anastomosis, which is where we join normal tissue again back to each other. Yeah, so we don't just cut things up. Before that, we tend to have to see the patient first when they first present, normally with colorectal cancers, with rectal bleeding or tenezzos, which is a sense of incomplete bowel evacuation, with alteration in bowel habit. Before this, they were going on a daily basis. Now they're going perhaps way too often, 5 or 6 times per day, or they just do not go. They develop unexplained constipation. Yeah. Or they have a suspicious breast lump. As far as ladies are concerned, when they have a breast lump, it's breast cancer to proven otherwise. But they're not all breast cancers. They could be just a simple breast cyst or a benign breast lesion. Or for ladies with particularly large breasts, sometimes they knock them subconsciously and they cause fat necrosis, which behaves and feels just like cancer. And these people need reassurances. So we need to perform a proper diagnosis of the cancer, stratify them, perform the correct form of blood test, imaging, as well as biopsy to reassure most of these patients that they do not have any cancers. Perform colonoscopy for those with rectal bleeding, for example, in a certain age group. I like the breast cancer and colon cancer are rising. Actually, the incidence is rising in the developing countries. We now approach a level which is fairly similar to those of developed nations. The highest incidence in the world for colon cancer is in the West, America, Australia, and Europe, and we are not far off. And we could see this pattern emerging in the Far East. Yeah, in the past, Malaysia, Singapore, Indonesia, Hong Kong, Japan, Korea, the incidence is not as high as what it was perhaps 40 or 50 years ago. It may have something to do with more available avenues of diagnosis, but we believe that there is a true high rise in incidence worldwide anyway. Yeah. The other thing which we will have to do is in terms of empathy to the patient, to learn how to break bad news to the patients properly and decide whether surgery is appropriate or not appropriate based on the stage of the cancer. Stage 1, stage 2, stage 3, usually surgery is appropriate. We have to give them the correct surgical dose, perform the surgery. Most of the operations which I do nowadays for the abdomen is done keyhole. We perform minimally invasive surgery. You perform 3 or 4 tiny holes. You can perform your dissection as good as when you were to do it with open surgery with a laparotomy. And we also have the robot which we can utilize for this operation. The robot is a form of laparoscopic surgery, if you like, whereby the robot is used by the surgeon to perform a more meticulous dissection, and it's particularly good for prostate cancer surgery, for radical prostatectomy, for early prostate cancer. Is as useful for colon cancer and head and neck cancers as well as upper GI cancers, but there is no real benefit of the robot with regards to that. It's something which we academics tend to want to do because we just want to better ourselves. There will be a role for it in certain cancers, particularly with prostate cancer. Yeah, so we need to plan the correct procedure for the correct patient at the correct stage. Yeah, for more advanced cancers. So yesterday we were referred a patient from a different private healthcare institution to the Center for a Second Opinion. This patient has had a previous prostate cancer for 14 years ago. Locally advanced, PSA on fairly stable. He's had the correct medical treatment for this, still on it in fact, and now he's developed a rectal cancer, but at the same time he's not very fit, still on dialysis, anemic, has cardiorespiratory issues, and despite him having cancer in the colon, he's probably not going to be fit enough for surgery. And at advanced age, probably the best thing for him is to just to keep a watchful eye and to see whether we will have to speak to the have a multidisciplinary meeting to talk about him as to whether a surgery is going to be appropriate or not, because he's got liver metastasis already. Yeah, and we believe the liver metastasis is because it's coming from the colon cancer, not the prostate cancer. Yeah, he's not even fit for a colonoscopy at present, so we will have to wait and see. Yeah, so it's not really that cut and dried surgery. Yeah, sometimes you just have to use a lot of common sense for that as well. Yeah. And when you perform an operation, you have to think that this is someone's father, someone's mother, someone's daughter, someone's sons. You have to do your best. I like to think of myself as a sous chef. You are the one with the recipe, but the recipe may change depending on the circumstances, and you have to create a dish which looks and tastes good. Yeah, and the outcome has to be good also. Yeah, there's no point operating on somebody and the outcome isn't very good. Yeah, that's not what you are there for. Yeah, then you follow these patients up afterwards. You're also the enabler. You see these patients on a post-operatively to look for on the short-term period to see that they've healed rather well, and to see whether there are any short-term complications, and follow them up on a long-term basis also to see whether they will develop new cancers. Colon cancers, for example, and breast cancer for that matter too. Once you have the cancer, that means the whole colon and rectum is unstable. You can develop baby cancers. We call them polyps. And these polyps will have to perform colonoscopic surveillance every so often at intervals, usually in the first 3 years annually, and then subsequently every 18 to 24 months. Whereas with breast cancers, while in the past, perhaps 50, 60 years ago, before the advent of breast conserving surgery, we tend to perform mastectomy for them. We still do mastectomy, but based on international guidelines, we perform mastectomy on select cases when the tumor is large compared to the breast size, multicentric, or it has involved the skin and muscle, which is called a T4 tumor. Yeah, and for those patients, we tend to give them pre-operative, before surgery, chemotherapy. Yeah, and then we perform the surgery then onwards. And the other indication, which is not mentioned in the books, is that if you were to perform breast conservation surgery, the remaining breast can develop new breast cancer. So we live in we are a developing nation. Like it or not, while breast conserving surgery is good for the patient as a whole, sometimes when you remove the breast and the patient lives in a rural part of the country, whereby further follow-up might be difficult. Further treatment, surveillance on the remnant breast and on the opposite breast will be difficult. So it is to some extent the patient's address and whether the likelihood of them coming back for follow-up matters. And sometimes we advise for them to undergo a much more aggressive operation, which is a mastectomy, because they might not come back for surgery, for example. Yeah. Next would be looking at the population at large. So those with breast cancers and colon cancers, not so much thyroid cancers, but these cancers tend to cluster in families. So once you have one family member, particularly when they develop the cancers young, their siblings are at risk, and you tend to ask them about their parents and about their second and third degree relatives also. So these patients will require further screening. Yeah, further screening. So their family members, we would counsel for them to come for fecal occult blood test or an outright colonoscopy, which is offered to them. Yeah, we also look at opportunistic screening for patients in a particular age group. Yeah, we in Malaysia do not practice population screening because in terms of cost benefit analysis, you probably spend too much money for too little yield. Not as many patients, not many patients that you perform colonoscopy on, you will find a cancer. So in this country, is mainly about opportunistic screening. But the drawback of opportunistic screening is that only a certain population will be interested. Only those who are concerned about themselves will come forward. Most patients do not really want to have a colonoscopy done because it's just the sheer thought about somebody putting a a scope down your back passage and having a look around is unpalatable. But there are other options such as fecal occult blood test, for example. Yeah. And lastly is our role in terms of general education to our own trainees, the future generation of surgeons. Yeah. We ourselves have to keep on our toes in terms of our own betterment, learning about new diagnostic means, but new surgical techniques, about new ideas, about a new paradigm shift in terms of cancer behavior. Yeah, and you just have to keep on doing that. Yeah, and also in terms of leadership, I think it's a good idea for us not just to be cocoon in our own world, but to also inform the population at large of the importance of awareness of the symptoms of breast cancer and colon cancer and thyroid cancer and the sort of people who might get these cancers, and for them to come forward and see a doctor. Yeah, that's important. Yeah, and some of us senior officers in the Ministry of Health or in surgical associations or medical associations, which has influence over how this information like this is disseminated to the public. Yeah, so surgery, as I've said just now, surgery remains essential in cancer management because you need standardized evidence-based care. So you can't really just willy-nilly decide, oh, this person is for surgery. What is the reason behind you doing that? Yeah, and like it or not, some cancers present as emergencies. Some of the photos I showed you just now were emergency cases: intestinal obstruction, bowel obstruction, upper GI bleed, lower GI bleed, patient in extremis regard, which necessitated you thinking on your feet as to what is the best modality of care so that they can recover and then perform the adequate amount of surgery for the cancer that just presented itself there. Yeah, and also in our secondary role in terms of surgical intervention for those whose cancers cannot be removed for cure, but to make their their remaining lives much more meaningful, for them to get out of trouble, feel less pain. Yeah, not jaundice, for example. Yeah, the placement of palliative stents and so on and so forth. And our role in terms of looking for cancers and educating the general public. This is my last slide. How do I think? How does a surgeon think, and how does a surgeon envisage as to what to do? Of course, this requires proper training. Yeah, you have to, for you to build a sound judgment, you have to be properly trained. You have to have adequate experience in the field that you want. Build the team around you. Prince Court Medical Center, for example, has the right set of doctors, from urologists to general surgeons to oncologists to hepatobiliary surgeons to breast surgeons and radiologists, which we engage and talk about cancers. We have multidisciplinary meetings. This is also what we do in the academic centers. Yeah, and we tend to learn from each other, and we tend to learn from mentors from local as well as from overseas, and send our trainees for adequate, proper training within the scope of the specialty. Yeah, and you have to base your decisions on first principles and on clinical evidence. You can't really that is what modern science of surgery is all about. Yeah, and at the end of the day, you have to think that these are people who are close to you. They are your patients. You virtually own them. They rely on you. They've come to you for help. Yeah, they're crying for help. Please do something for me. And they have the you have their ears. You have they believe that you can do something for them. So you have to do the right thing for them also. And the surgeon is only as good as your own rate of complication in your own hands, and the ability for you to minimize risks and to avoid any damage to the patient. Yeah, and you must know when not to operate. It's actually quite important also, when it's not appropriate to perform the surgery. Yeah, this is not about dollars and cents. It's about doing the right thing. Yeah, and of course, all this can only be done with if you have the right resources in the hospital that you practice. Yeah, This is my last slide, and I'm just going to show you a photo of me at the end of performing an abdominal perineal resection with my headlights still on. Yeah, and I do welcome questions from the forum. Thank you
Okay.
very much.
Lovely. Thank you so much, Prof. I think you always kind of re-energize our interest in the entire profession. And I think one of the concerns, and probably this is kind of related to the first question, Prof, is that in terms of cancer treatment, cancer management, now there's a lot of thought among the general public that, you know, no need to cut. Let's go ahead and just do chemo first. Oh, surgery is bad for you. I think one of the important points that you've done this evening is kind of point out to us, the viewers, how important this is and continues to remain the most important part of cancer management. So the question, Prof, that has come up is there a role for surgery in late cancers when you detect stage 3 or stage 4 cancers?
When let's go specifically to the first part of your question instead of the second part. Yeah, when you talk about chemotherapy and operative surgery, just to tell you an anecdote, when my father-in-law was admitted to this hospital for a ruptured abdominal aortic aneurysm, nothing to do with cancers. Yeah, when I told him he had to have surgery that very evening, the first thing he asked me was, "Tak ada chemo ke?" And this is from a lay person who knows nothing about surgery in general. So chemotherapy is part of the general psyche out there. They've heard that operations are painful, operations cause pain, anastomosis can leak. Yeah, Mr. A has gone to the surgery and he never got out of the hospital, ended up in ICU for 3 months or something like that. That, of course, that can happen. Yeah, of course that can happen. But choose your patients well, with adequate, with the correct response, the correct surgical dose, proper training, the meticulous surgery. Hopefully, this will not happen. And I like to think that in a hospital like this, the incidence of complications is low. Yeah, it's not zero. That's not possible, of course. You cut something up, there are of course risks. Yeah, it's not zero, but I like to think that the benchmarking in a hospital like this is as good as any international grade hospital. Yeah, so is there a role for surgery for late cancers? The answer is yes, but you have to look at the whole picture. Yeah, if somebody has a stage 4 cancer, age 80, yeah, has poor comorbidities like what the patient which was sent to us yesterday from this different private healthcare institution for a second opinion. Yeah, you're asking for trouble if you were to perform resectional surgery for that patient, because the cancer has the horse has bolted the stables, if you like. Yeah, any form of surgery for him will not improve his survival. You will not increase his lifespan. And surgery at that point in time will be purely on a palliative setting. So the idea is to keep him comfortable, not in too much trouble, preferably without a stoma. Yeah. So in this guy's case, he's still able to pass motion on a daily basis. He's not clinically obstructed. The cancer is located in a difficult part of the abdomen, in the mid rectum, which potentially can cause him intestinal obstruction at some point in time in the future. But he is already 82 with multiple comorbidities. We don't know whether he's going to survive until next year. He already has metastatic liver disease. If you were to ask an oncologist, for example, his lifespan is probably going to be 3 months at most. Yeah. In the meantime, he can also develop things like a myocardial infarct or a stroke. Yeah. So because of him having this cancer, you do not treat the cancer per se, but you treat the patient as a whole. Yeah, there's no specific indication for immediate surgery. There's no specific indication for him to be given a stoma. There's no specific indication for him to be given a colonic stent, for example, because those are all presumptive things which you can do to the patient, but at what cost? Yeah, his quality of life may not be as good. So I had to explain this to the patient's relatives, that coming to see me does not change the situation. What the doctors in the other hospital have said is absolutely right.
That's right, Prof. Thank you. And I think one of the interesting things that you put on one of your slides, Prof, was about how the surgeon actually acts as Sherlock Holmes, and in many cases, you know, when really no one can figure out when what's going on, it's the surgeon who, as the primary investigator, kind of goes in. Prof, there's another question on, what are the kind of commonalities between keyhole surgeries and robotic surgery? And is there what are the difference in terms of side effects? Why would you go for one or the other?
Keyholes, minimally invasive surgery is a form of surgery whereby you do not make a big incision in the abdomen or the chest, yeah, or the neck, for example. So the scope has become enlarged. It's not just the abdomen, but also the chest and the cardiothoracic surgeons working on the lungs, for example, yeah, can perform keyhole surgery. We call that VATS, yeah, video assisted thoracic surgery, yeah. We can also remove small lumps of the thyroid for early cancers through the axilla. We can also perform certain small cancers of the abdomen through natural orifices, through the esophagus and the stomach, making a hole in the stomach and removing it that way, so that you have scarless surgery, or through the vagina for that matter. Yeah. But laparoscopic surgery has been around for some time. In Malaysia, it started off with laparoscopic cholecystectomy, just removal of the gallbladder, in 1989 by Syed Nouri of UM. Yeah, but it has evolved, and we started off doing laparoscopic colorectal work in Malaysia. I would like to think that we are the pioneers in doing so. We started that in 2002. Our mentors came from Australia to come and help us set it up. Yeah, my colleague and I, and HKL back then. We did about 180 to 200 cases per year, quite a lot. HKL is has a very large catchment area. Yeah, huge. You used to work there yourself, you know what it's like. Yeah. And so keyhole surgery is where you perform surgery keyhole, and the location of the ports ergonomically suited for the anatomic location of the cancer. Say, for example, you want to operate on a rectal tumor, then you put the port sites in 3 or 4 locations, whereby you can angle your instruments accordingly so that the cancer can be removed in its entirety, only needing a small incision to remove the segment on block. Yeah. Nowadays, you can even do it as a single port operation. You take one little port, and this is where the robot might help, because robotic single port surgery is much easier, because the robot, then you do not have your cameraman and the surgeon knocking into each other's buttocks. Yeah, langgas ini, langgas sana, not a good idea. Yeah, so robotic surgery is really another way of performing laparoscopic surgery, keyhole surgery also. The robot has 3 to 4 arms, yeah, and nowadays there's one robot with 3 to 4 arms which can go in through one single port only. Yeah, in Malaysia still do not have that. The only region which has that at present is Hong Kong and Singapore. Yeah, that would be the next step in terms of robotic surgery. Yeah. So the current robot now is mainly used for prostate cancer, but also for rectal cancer. Quite good for that. And for head and neck cancers, which we tend to tell patients about that. So robotic surgery is where the surgeon controls the robot elsewhere. The robot is like a master and slave thing. You are the master, the robot is the slave. The robot is docked next to the patient. You have fairly similar looking laparoscopic instruments, which is controlled by the robot. You can cut, you can burn, you can dissect, you can stitch, you can do whatever you want, but the dexterity of the robot is such that it is superior to the hands of the surgeon. And if you are say you have tremors, for example, the tremor disappears because of the robot. It gets dampened out. Yeah, the robot is particularly good for pelvic operation, and in my opinion anyway, the best use for the robot is in radical prostate cancer, whereby you have to remove the prostate, avoid injury to the neurovascular plexus, so that the patient does not get erectile dysfunction. Erectile dysfunction, and at the same time the possibility of re-anastomosing, joining back again the urethra to the base of the bladder. Yeah, so only the segment where the prostate is lost, and to be able to perform adequate proper lymphadenectomy as well at the same time. So this is where prostate surgery is best utilized in prostate cancer. But everybody wants to use a robot now. So the robot is now also utilized by general surgeons, urologists, ENT surgeons. And why the Americans created the robot in the first place is so that they can perform surgery with in their submarines on the moon. Yeah. So one of the demonstrations which they had was to perform. The surgeons were controlling the patient was in Paris. Yeah. So the Parisian surgeons, but the control for the robot was in New York.
Oh, wow. Okay.
Yeah. Yeah, so it wasn't a gimmick. It was a
Right.
trial, and this is mainly one of the things
Military.
which the U.S. military is quite keen to do on. Yeah, because if they have ships all over the world, they have submarines, they have space flights and all that. So when they have people over with trauma, with tumors, with appendicectomies, with acute emergencies, they do not have to have they will have to have a surgeon over there, but maybe the robot can take over the job and the surgeon can be onshore.
Right. Right. Lovely, Prof. Prof, are we good for time? Are you okay with time,
I'm
Prof?
fine, yes.
Okay, lovely. There's just two more questions. One is, if I've had surgery for my colon, in the case of, I think, colorectal surgery, after that, will my colon ever return to normal?
In terms of resection of the colon, once the segment has been removed, it will not grow again. It's not like the liver. The liver is like the griffin, we call it. Yeah, the mythical griffin bird. When you kill it, it rejuvenates itself. Yeah, it's the only organ which does that. The other organ which can do that is the cornea. Cornea and liver, they rejuvenate itself. Whereas any other part of the body, once it's removed, it goes in the pot, it never comes back. You do not grow a new liver, you do not grow a new colon, you grow a new rectum. So if the question is, if post-colonic or colorectal or rectal resection, if you've had the surgery done, will life be normal again? That's a much fairer question, I think. The answer is yes and no. Yeah, there will be some repercussions as to what you've removed. Say, for example, you have a cancer fairly close to the anus, yeah, literally within touching distance of the finger, as you put in. That means the patient would, for oncological reasons, for the sake of cancer clearance, you have to remove the colon, the part of the colon, the whole rectum, and the whole anus, plus surrounding tissue. So you will not have an anus anymore. Right. So will life be different? Yes, you'll be living with a permanent stoma, but at least you'll be alive. Yep. Yeah, at least you'll be alive. If you were to perform a right hemicolectomy, for example, say I showed you a CT scan of a cecal tumor just now. You removed 40% of the colon, you re-anastomose, you join the small bowel to the large bowel, so the colon is now 40% shorter. Yeah. What drawbacks do you get from this? You'll probably get a little bit of diarrhea. If before this you will go to the toilet to pass motion once a day, you might go initially in the first few months 2 or 3 times a day. Yeah, most people will have to do that, but the body is clever. It readjusts itself. Yeah, and you tend to drop back down to only once or twice per day from then on, and you do not miss the colon then, therefore. So if it's not in the rectum, not too close to the anus, usually life goes back as per usual. In some cases, you might have to give this patient a stoma, usually temporary, sometimes permanent. But when the stoma is temporary, when you reverse the stoma back again without any complications, usually the bowel habit becomes normal again. You tend to forget about it too much. Yeah. But you must remember, because once you develop one colon cancer, the whole colon is unstable. You will require to come back for colonoscopic surveillance. For us to have a look with a camera inside, just make sure we go and nip all these baby cancers in the bud. All these polyps, must take them out.
Right.
Yeah. Most of us, unfortunately, have families with families of colon cancers. I have families of colon cancer on my father's side as well as my mother's side. I'm at the age whereby I should really get a colonoscopy done myself.
Right. Will do, Prof. And so the final question for this evening, Prof, from our viewers is, would you recommend pre-operative physiotherapy for patients?
Yes, definitely. When you operate on a patient, one of the risks that you can get would be, particularly the most common complication is not in the abdomen. When you perform a cancer resection, for example, colon cancer or small bowel or pancreatic or what, yeah, the most common 50% of all complications is pulmonary, the lungs. Yeah, the lungs. So for elective patients, for example, elective means non-emergency operations, elective patients. Patients who are older, patients who have a history of smoking or current active smokers, you know that they will be on table for 3, 4, 5, 6 hours sometimes. When the longer the duration of the surgery is, the more secretions you will keep in the lungs, the higher is the risk of the so-called atelectasis or lung collapse. Everybody gets some degree of lung collapse with general anesthetic. It's a question of degree only. And if you know that your patients will be bedbound because they are in pain for some time after surgery with ileus and abdominal distension and difficulty breathing and shallow breathing because of the pain that they have to endure following surgery. So all this contribute to atelectasis, which is lung collapse just now. So in order to minimize the risk of atelectasis, which will happen anyway to some degree, and to minimize it, you have to give this patient education and pre-operative physiotherapy to the chest. It's not physiotherapy about the limbs and all that so much. That's important, but not as important, because we know for sure that 50% of all complications arise in the lungs. If you ignore that, the patient, you'll develop pneumonia. The patient can die. You can die from the pneumonia following surgery. Not a good idea. The intent of the surgery was right, but the outcome is poor. So why bother in the first place? So in every hospital, if surgery to the abdomen is contemplated, it's complex major surgery. So preoperative chest physiotherapy is mandatory.
Right. Will do, Prof. Prof, thank you so much for this really enlightening session. If anything, I think you've helped put the spotlight back onto surgery. Sometimes it gets moved a little bit away in when all these sexy new therapies like immunotherapy and all that come into the picture. There's always the importance of surgery as the primary curative mechanism in cancer, Prof. So
not so much the surgeons, maybe the robot will take over.
But it always, I think you had it very accurately just now. You said master and slave. So as long as the surgeon remains the master. Prof, as we wrap up this evening, could I kindly kind of ask you to give us one or two takeaways that you think would be helpful for our viewers?
Thank you, Mr. Murali, or Dr. Murali. Firstly, if you were to have symptoms or you have a family history, please do seek advice anyway. I wouldn't say come to the hospital, but at least seek advice. We are more than happy to give you advice. We're more than happy to see you. Lots of people, when they have rectal bleeding or they have alteration in bowel habits, and the reason why they present with third or fourth stage cancer is because they tend to be afraid as to what might the price might be, if you like, the price might be for their consultation with a doctor. Of course, my role is to cure you. So if need be, I will have to offer you surgery. But by and large, most of these patients with alteration in bowel habit and rectal bleeding and lumps in the breast and lumps in the thyroid, they're more likely to be benign or functional, or hemorrhoids or fissures or polyps, for example. Not infrequently we see patients who are older, the right age category, if you like, for colon cancer presenting with alteration in bowel habit. The vast majority of them, the colonoscopy is normal. Which means that, say, HKL, for example, we perform 1,200 colonoscopies per year annually, without fail. And the yield for cancer from those, of course, some of them will be surveillance colonoscopy for those with previous cancers, but that's a small fraction only. Most of them actually are reactive, not even coming for screening. They just come because they just don't feel quite right. We have to be defensive. It being the number one cancer in men, right, number two cancer in women, and 20% of all cancers in Malaysia. So the correct thing to do is, when they come to see you with symptoms like that, you have to perform the colonoscopy, like it or not. Right. Not FOBT, colonoscopy. Right. FOBT is mainly for population screening, not so much. When they come to see you with symptoms, you have to do it as a defensive measure. It's okay if it's negative, doesn't matter. At least they know for sure that it's not going to be there. But a small percentage will have polyps, some will have tumors, but the majority will be normal, which means that a lot of us has irritable bowel, actually. Yeah, a lot of us has irritable bowel. Where we live, our lifestyle is like that. We develop Western diseases, so we also develop their irritable bowelness, if you like. Yeah, but those patients in whom we diagnose a tumor with symptoms like that, most of them will be Dukes B or C, so stage 2 or stage 3 cancers. A small percentage will be stage 4 cancers. Very rarely will be stage 1 cancer. Yeah. Should we perform a population screening? I don't think the health service has the money for that.
Yep.
Do we do opportunistic screening? I think if you have a family history, if you have symptoms, you better go and see somebody.
Will do, Prof. And on those kind of very important, insightful words, we kind of draw this evening to a close. Thank you very much, ladies and gentlemen. This was Consultant General Surgeon, Professor Dr. Faisal Jabbar of Prince Court Medical Center. Good evening, Prof. Thank you so much. Pleasure to see you, and of course, hope to see you very soon again. So, ladies and gentlemen, as we draw this evening to a close, if there are any further questions, please feel free to kind of put it onto the Facebook comments here or at Prince Court Medical Center's page as well, and we'll be very happy to get back to you with some answers as well. Feel free, for those who haven't got on to watching the earlier segments of the program, or if you missed it, the videos continue to be on both our Facebooks, Prince Court Medical Center, as well as ours at National Cancer Society Malaysia. And thank you very much. This session this evening, we had three very eminent clinicians, Consultant General Surgeon, Professor Dr. Faisal Jabbar, Consultant Clinical Oncologist, Dr. Muhammad Azrif, and Consultant Urologist, Dr. Goh. With that, we'd like to thank you very much and bid you good night. And this is coming from National Cancer Society Malaysia and our sponsors, Roche Pharma Diagnostic and Chat Services. Thank you very much for kind of putting this session. And we'll see you soon at our next session of Cancer and I. Good night.